Okay, so let us discuss about the cerebellar examination today. So first of all, we need to know that what is the function of cerebellum in our body. So the most important function of cerebellum in our body is the coordination of voluntary movements, right? So let us try to understand this by taking a cross section of the cerebellum. So if we take a cross section of the cerebellum, so there are three parts of the cerebellum, right? So first of all is the vestibulocerebellum. Then there is spinocerebellum, and the third part is cerebrocerebellum. So the vestibulocerebellum has a role in balance and eye movements. Spinocerebellum has a role in control and coordination of voluntary movements, right? And cerebrocerebellum has a role in motor planning. So what if there is a lesion in the cerebellum, be it of any etiology, be it a vascular lesion, a demyelinating cause. So irrespective of the etiology, if there is a lesion in cerebellum, there would be a loss of this coordination, right? Which manifests as incoordination while performing voluntary movements, which is tested by a number of tests that we'll see subsequently. Then there could be difficulty in balance, which manifests as ataxia. There could be a difficulty in eye movements, which manifests as nystagmus. Right. So this is about cerebellar lesion. What about if there is a basal ganglion lesion? Basal ganglion, the predominant function in our body is first it is motor planning, and then it also performs coordination and control of associated movements. For example, while walking, the swaying of hands, and while talking, the facial expressions. So therefore, when there is a disease of the basal ganglion, for example, Parkinson disease, so what do we see in that? There would be reduced arm swing would be there. There would be facial hypomimia, that is reduced facial expressions while talking. Versus when we see a cerebellar disease which has a predominant control over voluntary movements, so there would be incoordination or difficulty in performing the voluntary activities, right? So this is the major difference between basal ganglion controlling associated movements and has a predominant role in motor planning. Cerebellum has a predominant role in control of voluntary movements and has a secondary role in motor planning, right? And also if we see this spinocerebellum, so this is the map of our body in spinocerebellum. So this is how the body is represented. So if we take, this is the midline of cerebellum, which is known as the vermis. So in cerebellum, if there is a lesion on this side, that is the right side, all the signs would be of the same side. So in cerebellum, there are ipsilateral signs and symptoms of any lesion, right? Similarly, if there is a lesion on left side, there would be signs and symptoms of incoordination on the left side. And when there is a lesion in the midline, that is in the vermis, that will manifest in the form of truncal ataxia, because the trunk is represented in the center, right? So truncal ataxia would be there, right? So this is the basics of the anatomy and physiology that we need to know in order to understand the cerebellum. So the basic test of incoordination that we do in a cerebellum is the classical finger nose test. So we ask the patient to touch the examiner's finger, right, and then to touch his own nose. So this is a video showing the same. So when we are asking the the patient to touch the pen or the examiner's finger, he is facing difficulty. Similarly, he is facing difficulty while touching the nose. So why is it? Because he is not able to judge the rate, the range, force and direction of this voluntary movement, which was the function of cerebellum. So this is how this is manifesting, right? So this is the classical finger nose test, right? So apart from so why is this happening? So let us try to understand this, the physiology behind this incoordination. So let us say that this is the cerebellar nuclei, any deep nuclei of cerebellum. So whenever we give the command to the brain there are climbing fibers which carry the proprioceptive impulses to the cerebellum. So this deep nuclei would give a stimulatory response and excitatory response, and the movement would start, let's say touching the examiner's hand. Now these fibers are also going to the cerebellar cortex, which contains a number of cells like the Purkinje cell. So this Purkinje cell has a inhibitory control over this deep nuclei. So this will decide that when do we stop the movement. For example, when I ask the patient to touch the examiner's finger, so whether he has to stop here or he has to stop here. So this has to put a control over this deep nuclei, the movement which is started. So now in cerebellar lesions, what is happening is this control is gone because of a infarct, because of a demyelinating illness, or whatever be the etiology. This control is gone, resulting in a overshoot movement or a undershoot movement, pass pointing, rebound phenomenon. So this is the physiological explanation behind all the signs of incoordination that is happening, right? So now apart from finger nose test, there are a number of tests that we should perform while examining for cerebellum. So this is one of the mnemonic that one of my professors once told me. So D stands for dysmetria, then there is dysdiadochokinesia, then there is dyssynergia, right? So triple D hit, that is hypotonia. Then there are intentional tremors. Then there are titubations. Then N stands for nystagmus, A for ataxia, abnormal gait, P for pendular knee jerk, then S for scanning speech, R for rebound phenomena or Romberg's test that we'll discuss subsequently, right? So let us start with dysmetria that we already discussed with the finger nose test that we performed, right? Apart from the and we know the physiology behind it also. Then the second test is dysdiadochokinesia. So dysdiadochokinesia, we ask the patient to perform pronation and supination rapidly, right? Alternately pronation and supination, first with one hand and then with the second hand, again to check for coordination, right? Because patient is not able to perform these complex coordinated movements together. So there is dysdiadochokinesia. The third is dyssynergia, that is difficulty in performing complex movements together. So one of the tests for it is tandem walking. So what do we ask the patient to walk on a straight line with the heel of one feet touching the toe of other feet, right? There should be no gap in between. So patient walks along a straight line and we test for imbalance, right? So this is the third test, that is the tandem walking. Now after triple D, there is HIT, that is hypotonia. So always and always remember three differentials of a patient with hypotonia. Number one is any lower motor neuron lesion. Number two is a upper motor neuron lesion in shock stage, right? And the third is a cerebellar lesion. So always remember this as the differential of hypotonia. These three are must know. Apart from that, there can be other causes also, like a patient on sedatives, patient in deep sleep, patient with hypokalemia. They also can have hypotonia, but at least these three causes we should always remember as the differentials for a patient with hypotonia, right? Apart from that, there would be is for intentional tremors, right? So again, this can be demonstrated by this finger nose test. So we can see that these tremors are more when the patient is trying to approach the target, be it the nose or be it the pen. So whenever he is trying to approach the target, the tremors are increasing. So what are tremors? These are again rhythmic alternate contractions of agonist and antagonist muscles, right? So this is increasing when the patient is approaching the target. So this is classical intentional tremors of a patient with cerebellar disorder. Then coming to the next finding in a cerebellar disorder, it is titubations. So what is titubation? Titubation is a nodding of the head, right? So that happens again because of hypotonia of the neck muscles. So there is head nodding. So this is very similar to the demusset sign that we get in aortic regurgitation. There the nodding is because of aortic pulsations, but here the nodding is because of intermittent hypotonia of the neck muscles, and therefore there is head nodding known as titubations, right? Coming on to the next finding, that is nystagmus. So there are a lot of things that we need to know in nystagmus, but I'll tell the minimum that we should know. So nystagmus is rhythmic to and fro movement of the eyeball, right? So first of all, we need to know that nystagmus can be physiological. For example, while looking at extremes of gaze in optokinetic nystagmus, these are common causes of physiological nystagmus. Now, when we talk about pathological nystagmus, so first thing that we need to know whether the nystagmus is pendular or the nystagmus is jerky. So when I say pendular, that means just like a pendulum, the nystagmus is equal in amplitude and speed on either side. So this is pendular nystagmus, classically seen in patients with sensory deprivation in infancy. So the fixation reflex in them is not developed. So there is a pendular nystagmus. Jerky nystagmus, on the other hand, would have a difference in amplitude and speed on either side. So there would be a fast component and there would be a slow component of nystagmus. So the direction of nystagmus, when we say, is always described in the form of the fast component of nystagmus. So when I say that nystagmus is towards left side, that means the fast component is towards the left side. And we need to know two important differentials for jerky nystagmus. Cerebellar nystagmus, in which the fast component is towards the side of the lesion, and labyrinthine or vestibular causes, in which the fast component is away from the side of the lesion, right? So first we discussed about pendular versus jerky nystagmus, then we discussed about the direction of nystagmus, right? And then the gaze in which we test, like cerebellar nystagmus is observed in horizontal gaze, right? So we test in the horizontal gaze for it. There are other causes for vertical gaze, downbeat nystagmus, upbeat nystagmus, right? But this is the minimum that we need to know, that in cerebellum there is nystagmus which is jerky, which is the fast component is towards the side of the lesion in the horizontal gaze, right? So now there is another thing that we look is what is the grade of the nystagmus. So let us take the example that this patient has a left cerebellar lesion. So obviously the fast component would be towards the left side only, right? So it would be towards the left side. Now if I ask the patient to look on the left gaze here, right? So now when the nystagmus is present, that is known as grade 1. If the nystagmus is present when I ask the patient to look in the center, then it is grade 2. And if the nystagmus is present when I ask the patient to look in the direction opposite to the fast component, right? So then it is grade 3 nystagmus. That is fast component towards left side, which is manifested when the patient is asked to see on the left side. Fast component towards the left side, which is manifested when the patient is asked to look on the center. Grade 3 is fast component toward the left side, which is manifested even when the patient is asked to look towards the right side. So that is grade 3 nystagmus. So this is all by taking an example of a left cerebellar lesion. Similarly, there could be a right cerebellar lesion, then there would be grade 1 towards right side, grade 2 in midline, and grade 3 towards when the patient is asked towards to look on the left side, right? So this is the grade of nystagmus that we say, right? So if we look at this video, so there is nystagmus in the eyes with fast component towards the left side, and which is more prominent when the patient is asked to look on the left side, right? So that is a grade 1 nystagmus. Now coming on to the next finding, that is ataxia. So ataxia is that the patient has a classical wide based gait, which is also known as alcoholic gait or drunken gait, right? So when I say wide base, that means the intermalleolar distance is more than 12 centimeter. So when the patient, because of difficulty in coordination, tries to walk with his legs apart with the intermalleolar distance being more than 12 centimeter, so that is known as ataxia or wide based gait, right? Coming on to the next finding, that is pendular knee jerk. So in order to test the pendular knee jerk, patient first of all should be seated with the leg freely hanging by the bedside, so that there is enough space for the movement of the limb anteriorly and posteriorly. Now when you give a knee jerk, when you give a tap, there would be this leg would oscillate, and if there are more than equal to 5 oscillations of equal amplitude, then it is known as a pendular knee jerk. So at least 5 oscillations of equal amplitude should happen before decay in order to call it a pendular knee jerk. So this, apart from cerebellar lesion, is also seen in chorea, right? So these are the two causes of pendular knee jerk: cerebellar disorder and chorea. The next finding is a scanning speech. So when I say scanning speech, that is, first the patient speaks slowly, then the patient splits the words in and speaks syllable by syllable and takes intermittent pauses in between. So this is classical of a cerebellar speech. Like if I say the patient to say something, right? So he would say it slowly with syllable by syllable, giving force on some variables and taking pauses in between. So that is known as the scanning speech or scatotic speech, right? For example, scanning, right? So this is how the patient would speak. Now coming on to the last in NAPSR, R for rebound phenomenon. So what is rebound phenomenon? Again, if I ask the patient to flex his forearm and I apply resistance, then he would flex. Now if I suddenly release this pressure, now the patient won't be able to stop this movement, and this his arm will hit his face. This is because he is not able to control the rate, range, direction and force of movement. So this is the rebound phenomenon. Another R is Romberg's test. Now one thing we should remember here is Romberg's test is not a test of cerebellar dysfunction. It is a test of sensory ataxia. This is a very important thing. Like classically, Romberg's is for sensory ataxia, that is the posterior column dysfunction. So what we are doing in a Romberg's test is ask the patient to stand straight with his heels touching each other and the feet apart, with his arms by the side of the body. First with the eyes closed, so patient will stand normally. Now when you first with the eyes open, so patient would stand normally, and now when you ask the patient to close his eyes, there would be swaying. This is known as Romberg's test positive, and this is classical of a sensory ataxia. So in cerebellum, what would we see? In cerebellum, even when the patient has his eyes open, there would be swaying, right? And this swaying would persist even when he closes the eyes. So if so, first of all, we should not use the term Romberg's for a cerebellar dysfunction. But if let's say someone asks you that what would your findings be when you perform a Romberg's test in a cerebellar disorder, so our findings would be that patient would sway even with his eyes open and would sway even when the eyes are closed, right? So this would be the findings. Otherwise, this term should be reserved for patients with sensory ataxia. That is, with eyes open, patient would stand normally, but when eyes closed, patient would start swaying. That is known as Romberg's test positive and is seen in sensory ataxia, right? So this was triple D hit NAPSR. Apart from this, the incoordination in upper limbs we tested via finger nose test via dysdiadochokinesia. Similarly, in lower limbs we can test by either asking the patient to make a circle with his lower limb in the air, right, to test for coordination. Next, we can ask him to lift his one limb, to place his heel below the tibial tuberosity on the shin on the other limb and to move it down, right? And then again, once it approaches the ankle, keep it on normally, then again do repeat this. So this is repeated rapidly in succession to check for coordination. Similarly on the other side, this is the heel shin test. Other test we can do is we can put our finger here, examiner standing in the foot end, and asking the patient to touch that his great toe to the examiner's finger. So these are some of the tests for incoordination or dysmetria of lower limb. Upper limb we have already discussed. So these were some of the important tests that we should perform while testing for cerebellum, and gait should never be forgotten.